Let's go ahead and get started. Can we pull the first slides? So unfortunately, Lisa, who's our executive officer, Dr. Kachnik, is had to leave early for some other commitments. And she asked me to share some slides that she normally would have shown during her introductory remarks. Next slide, please. Or do I have control of this? So, you know, as Dr. Kachnik always likes to remind our group, you know, there are plenty of opportunities for our members to get involved. First and foremost, we're now getting to the point where, as a committee, we can sponsor studies as well. We're still kind of working out the kinks on how that's going to work with regards to statistical support. But you know, there will be a day and time when our committee will be independently able to sponsor studies. As always, like Dr. Roca and I always like to remind everybody, there are opportunities to do secondary endpoint analysis on studies that are in progress, that are being developed, and those can be proposed. So if you have ideas, please come to us and we can integrate you into the study, even if you haven't been involved with the development of that study. But if you have a translational idea that you want to propose to the PIs, we can have that discussion. And then we've done this in the past. Dr. Ghalami has done this with several studies. We do secondary analysis of studies that have been completed, and our committee has been very successful. We have multiple publications from our committee on secondary analysis of studies that were done in the past. An example of that was SWOG 0807, the one that looked at the use of radiation in biliary tract cancers. So these are trials that are kind of hot off the press. The very top one is by our very own Dr. Sham, who will be presenting an updated update on the study, which is a randomized multicenter trial of lanaritide for prevention of postoperative pancreas fistula. There are other studies that we've been involved with that are also either started or about to start. SWOG 2310, which is a phase 2 randomized study testing non-inferiority of shorter course radiation versus standard fraction radiation. The GU committee is developing a concept on bladder preservation after chemoradiotherapy or immunoradiotherapy for muscle invasive bladder cancer. And then the imaging thoracic PI is Larry Schwartz, accelerating drug and efficacy evaluation through growth rate and overall survival correlation. So these are studies that are kind of hot off the press, or either about to start or still in the later parts of development. Now, there are opportunities to get funding. First of all, if you know, for the next meeting in Seattle, if you need travel funds, we do have travel funds available. Just need to send me an email, and you know, I can connect you with the right people. And if the travel funds available, we can fund your trip to Seattle. And then there's grants that are available through the Hope Foundation. And I can tell everyone in this room that they're looking to give money away. I mean, like, there's a dearth of submissions to the Hope Foundation. So if you have a good idea, and I'm going to show you what's available in a second. The Hope Foundation is celebrating their 30th year this year. It's a big deal. They're the vehicle which really funds the SWOG meetings and research pilot funding, and really opportunities for young investigators. So, you know, I would encourage everyone to take a picture, scan this, and if you have an opportunity to donate to the Hope Foundation, please do so. You know, they're really an important part of SWOG, and you know, it started with Joe Horn as a single employee, and now there's 67 employees in the Hope Foundation. So this is a good cause, near and dear to everyone who's part of SWOG. So go ahead and scan that if you can, and if you have an opportunity to make a small contribution, however small it is, it will be much appreciated. And it's celebrating the 30th year. They have, you know, really put out a lot of press. So if you go downstairs one floor at the Hope Foundation table, they have really nice book that they've published with stories of patients that have been impacted by what they've done, and the story of how Hope has evolved over 30 years. And these are some links that you can go to kind of look at some stories and some interviews from the leaders within the Hope Foundation. So these are some of the opportunities for funding. There's a SWOG Early Exploration and Development to Seed Funds, $50,000 for preliminary research leading to future trials. Applications are due in December. The Coltman Fellowship, $50,000 Early Career Award, 2-year fellowship in learning clinical trial methodology. The Impact Award, which is due next year in January, $250,000 awarded for funding innovative SWOG research, leveraging resources from trials or translatable to future studies. And the SWOG Career Engagement, again, $50,000 for 2 years, salary support to provide protected time for mid-career investigators to pursue clinical research. So, again, I was at the Hope Board meeting on Wednesday, and the theme there was we need to get more people to apply. And so, if you have a good idea that, you feel is worthy, I would encourage you to apply. I think, the chances are pretty good that you'd be given strong consideration. Recent news, as everyone knows, Dr. Lara and Hirschman will be serving as a new group co-chairs. You may have heard that the NCI has delayed the grant application for 1 year. So there was a board meeting this morning, and they voted for Dr. Blanke to remain as chair until the end of the spring meeting. So Dr. Blanke will remain as the chair of SWOG until the end of spring meeting. And what they're trying to do is coordinate the group chair with the grant cycle. So, the grant cycle for for imaging, for statistical support, and for SWOG as a whole has been delayed 1 year. The other thing that's kind of exciting is that we will hopefully be thinking about planning a retreat at the Seattle meeting. We will have funds available for our committee to actually have a retreat. So if you have an idea on a theme for that retreat, that we could hold during the Seattle spring meeting, please send that to myself or Dr. Roca, and we can entertain different themes and ideas about what the retreat is focusing on. We want definitely to pick something that's going to help propel us forward in terms of generating ideas, publications, and involvement in clinical trials. Any questions? With that, I want to introduce our first and invited guest speaker, Dr. In. Oh, yeah, Maggie. So, the surgery committee is considered a support committee. There are disease committees like GI, breast, melanoma, GU, and historically only the disease committees could actually propose a clinical trial. Now, there are several support committees like radiation oncology, surgery, imaging, and those in an effort to increase SWOG presence, SWOG trials, SWOG participation, enrollment, which has been down relative to the other cooperative groups. Dr. Blanke has decided to let the support committees develop their own ideas and sponsor their own studies. So we can develop a study on our own without being involved with a disease committee, although most studies will involve participation, and then we can then submit that to the executive committee for approval, and then it goes through the same process as it would if it was through a disease committee. Yeah.
That's very helpful.
Yeah. Yeah. So we've always considered that as a good first study to sponsor, but it looks like that's actually going to go through the GI committee. But the rate limiting step right now is statistics. We right now are still being supported by Catherine, and she is just overwhelmed with all the proposals within the GI committee. But the hope is that we'll get our own statistical support in the surgery committee that will then kind of allow us to bypass the queue that's in the GI committee.
I think that.
Yep.
The feedback after everything that.
Mhm. Yep. Any other questions? Great. So our first speaker needs an introduction, Dr. Andrew Lowy, who really is the person who got me involved in SWOG and recruited me out of fellowship. And so I owe a lot to him in terms of my own career development. He's currently a professor of surgery and adjunct professor of pharmacology, the Levine Family Chancellor, Endowed Chair in Surgical Oncology, Chief of Surgical Oncology, and Associate Clinical Director of Surgery at the Morris Cancer Center at UC San Diego. Andy?
Okay, thanks. Oh, okay. Thanks, Sai, for the invitation to speak. I gave a presentation, I don't know, maybe it was 6 months or a year ago, about this topic at the GI committee. So some of you have heard a little bit of this story, but I've included a lot more data, including what's in our paper, which is currently under review. And I think this is a fun, exciting story because it kind of follows how we often make discoveries based on our care of individual patients. So I will start in that vein, and this is Betsy Childers, who is a resident at University of Cincinnati who spent some time in my laboratory and who's now a fellow at surgical oncology fellow at Moffitt. And she wrote and published this case report in 2021, published in JCO Precision Oncology, about this patient of mine who was a 48-year-old man who had presented with mucinous carcinomatosis of appendiceal origin. He was treated at Creighton University by Brian Logie with cytoreductive surgery and HIPEC. Many of you know Brian. He's very experienced cytoreductive surgeon. He achieved what he called a CCR0 cytoreduction. The pathology was mucinous carcinomatosis peritonei low grade. And unfortunately, as many of you who do this operation know, we do the best operation. We think, went perfectly. Patient developed no complications. Everything went well. And yet he recurred in 1 year with multifocal recurrence. As such, he was placed on, essentially standard of care chemotherapy that we all use for colon cancer, FOLFOX, and unfortunately, his disease continued to progress. He presented to me in 2016 at UCSD with abdominal pain symptomatic from his disease, basically looking for treatment options. I told him that I could debulk him for palliation, but that curative surgery was clearly not going to be feasible. We did that, and then we went on a search for novel therapeutics. As most of you know, most of these tumors are very hypocellular. We sent it for next generation sequencing. It was too hypocellular, so that couldn't be done. And this was just at the beginning of assays for circulating tumor DNA, which we sent. And he had the interesting finding of having cyclin D amplification, actually not overexpression as it says on this slide, really an amplification. At that time, most of us are not breast cancer doctors, but at that time, the CDK4/6 inhibitor palbociclib had just been approved for use in breast cancer, hormone receptor positive breast cancer. And there was a lot of speculation about biomarkers that would predict response to these agents. And cyclin D amplification was one of the putative biomarkers thought to be, to perhaps predict response. So we enrolled him on a personalized cancer therapy trial called PREDICT at UCSD, and we were able to obtain palbociclib for him. And can you advance? There we go. And this depicts his CEA during his care journey. So you could see in 2014, when he was diagnosed, his CEA was a little bit under 10. He had his HIPEC surgery and it went down to about normal. He developed recurrence and progression on FOLFOX. His CEA rose all the way to a high of in the 20s. And then we debulked him. It came down a bit. And then we placed him on palbociclib. And this gentleman has been on palbociclib now for 8 years as a single agent, with minimal progression of his CEA. His CEA nadir'd at around 7. I saw him a couple of weeks ago, and it was, I think, 10.5. He's beginning to have some symptoms. So I think his MRIs have not really changed, but I think he's probably having a little bit of progressive disease. But now 8 years on this single agent, and so there we go. And so I think most of you know the biology of of cyclins and CDK4/6, which promote cell cycle progression by phosphorylation of RB. The CDK4/6 inhibitors, palbociclib, now ribociclib, and abemaciclib are all approved agents in breast cancer. And what we learned, through the Paloma trials, which were 3 large breast cancer trials, which led to registration of these agents, is that cyclin D amplification is actually not a biomarker for response to these agents. It was disproven. And after we treated this patient, I went for a series of years looking for more patients like him who had cyclin D amplification to treat. And lo and behold, found exactly 0 of them. So I began to kind of reconsider, our thought process about this, and was thinking, is this guy just a unicorn, like a weird thing that you're never going to see again your rest of the career? Or is there something that we're missing here that's more fundamental about the biology of this disease that we need to understand better? And so there really are no preclinical models for appendix cancers of any type. There are actually no cell lines in ATCC. There's no cell lines. A few labs have now made a few patient-derived xenografts, but there really are no, good models, certainly not of human disease, certainly not that recapitulate the microenvironment. And Venu has done some beautiful work in pancreas cancer using this model called slice culture, where you take a 150 micron or so section of the whole tumor from the patient and culture it viably in the laboratory. And we had the idea of trying to adapt this technology to study appendix cancer. And so a really talented postdoc in my lab, John Weitz, who'd done some of this work actually to study diabetes and using slice cultures of normal pancreas, went to work, and we were able to successfully develop this method, which we published last year in Clinical Cancer Research, to study appendix cancer. And you can do a lot of things with these models. This is just a slide depicting kind of live dead staining. All the green cells are living cells in the culture. And so you could see that this slice culture is extremely viable. And even out to 7 days, you end up with 60 to 80% viability. The picture on the right is just a slide depicting the ability of cells to actually respond to stimuli. This is actually a calcium-based assay. I don't think I can do it based on how we're set up here, but it's a demonstration that the cells react to stimuli, in a physiologic manner. And so we sought to use this model to study the effects of CDK4/6 inhibition in these patients. And so what you see here is a slice culture of a patient, donor 229, who had mucinous appendix cancer, and on the left is control. And this media is we put EDU into the media, which is incorporated into replicating DNA. It shows up as a green spot. So these greens, hopefully you can appreciate those green spots, which are overlaid by pan-cytokeratin staining. So these are epithelial tumor cells that are proliferating. And you can see what happens to the green spots in the setting of palbociclib. Basically, they all go away, or most of them go away. And there's somewhat they're dose responsive. The higher dose you use, the more effect you get. And we observe this time and time again in patients with mucinous cancers of the appendix. Back in 2014, another surgical resident who was in my laboratory, Nikki Babicki, co-authored this study where we looked at the genome of mucinous appendix cancers using laser capture and then digital PCR. And what we published was the finding that these tumors have an extremely high rate of co-occurrence of KRAS and GNalpha-S mutations. GNalpha-S is the activating subunit of a heterotrimeric protein coupled receptor. And that this was that the genetics of this tumor were really, much markedly different than certainly than colon cancer. We saw very few tumor suppressor gene mutations. It seemed like these tumors are really driven by the co-activation of these two oncogenes. And interestingly, when you look through the cosmic database, the two most common tumors, human tumors that have this mutational pattern are mucinous neoplasms of the appendix and coincidentally IPMN, which was another disease that I treat as a pancreas surgeon. So, and you can see the similarities of the biology and the natural history of these diseases. They're both highly mucinous, secretory tumors that grow very slowly, indolent growth patterns. So it's very interesting because it suggests that this co-occurrence dictates a certain type of biology. So with that understanding, we started to look at more and more tumors, including some IPMNs, some colorectal cancers. We were fortunate to find a colorectal cancer that was GNAS mutant, and other mucinous colon cancers, which are not. The majority of them are not. But when we put all the data together, what we found is, if you look on the left, is that any of the tumors that had GNAS mutation have a lower EDQ incorporation rate, which is similar to what you'd expect based on their biology. They grow slower, et cetera, than tumors that like traditional pancreas cancer or colon cancer that's not GNAS mutant. And in addition to that basal lower rate of proliferation, they respond much more potently to exposure to palbociclib with respect to inhibition of their proliferation. We then went and did a search of the DepMap database, which is a database put together, for those of you who don't know, by the Broad Institute, where they look at hundreds of cell lines and their dependencies on certain genes or their responses to certain drugs. And so you can do all of this in silico searches, and we looked at what were dependencies to GNAS mutant tumors, and you can see palbociclib was one of 7 drugs that popped up as a drug that would be effectively treat GNAS mutant cells. So this kind of led us to confirm kind of our initial working hypothesis that there's something fundamental about these tumor biology. So we went on to enroll 15 more patients on the PREDICT trial, with the enrollment criteria being that they either have to have GNAS mutation or they had to have a tumor type like mucinous appendix cancer, or IPMN, which had a very high rate of these mutations, because in some patients, like the index patient I presented, we couldn't get any DNA from the tumor to sequence. And so you can see in this study, 80% of the patients had co-mutation of KRAS and GNAS. One patient had KRAS and no GNAS. One had the other way around. And a couple, including the index patient, we could never adequately sequence. So I'm going to show you the data from these 16 patients, whose average age was 61. About 2/3 were female. You can see that 75% of the patients had at least 1 line of therapy, and 4 of the patients had 3 lines of therapy or more. So a quarter of the patients had multiple lines of therapy. Almost all the patients had prior surgery. 13 of the patients had appendiceal primaries, 2 unknown primaries, and 1 patient had mucinous adenocarcinoma metastatic to the peritoneal surfaces from a pancreas cancer that arose from IPMN. And so what you see there in the waterfall plot is the CEA response of these patients. As most of you know, getting RECIST criteria for these types of tumors is really not possible because of the extensive mucin production. And so we use CEA as a surrogate for response. And you can see that 80% of the patients had a decline in their CEA on single agent palbociclib. And this is the spider plot to demonstrate the trajectory of their CEA responses. And, it was very apparent to us that this was a therapy which was having a biologic effect, on these patients. And so this is the swimmer's plot showing most of the patients are still on therapy. The median follow-up is now about 15, 16 months. Median progression-free and median overall survival have not yet been reached. We're very excited about, about the benefit of this, especially in this patient group who many times is only moderately symptomatic. And this is an oral agent which has very, very minimal toxicity. These 16 patients, we had 2 dose reductions for grade 3 fatigue. Nobody has come off drug, and most of the patients essentially really have no side effects. It's a 21-day on, 7-day off schedule, oral once-a-day medication. So to conclude, this part, we found that appendiceal slice cultures are a valuable model to study this tumor type, and I would posit other rare tumor types. Based on the successful treatment of these patients, we hypothesize that this is a novel strategy for treating patients with these KRAS GNAS mutant GI malignancies. And it really raises the exciting specter to me that this strategy could be used in other innovative settings, perhaps as a chemopreventative agent for patients with high-risk IPMN who are bad surgical candidates or elderly or don't want surgery. So other potential places where this could be, this strategy could be employed. So I presented at the SWOG meeting previously that we looked at the U.S. collaborative database of greater than 2,000 patients undergoing cytoreductive surgery. And if you look at patients who have high PCI scores, we use 25 and above, who undergo cytoreductive surgery, they have a relapse-free survival of about 14 months. So recurrence is really frequent, as we all know, in these people who have big disease burdens. And so we put together the null hypothesis that palbociclib could, as an adjuvant treatment, and in this case, I have up here abemaciclib, and the reason for that is abemaciclib is the only one of the CDK4/6 inhibitors that's available to us through the CTEP compendium. I had meetings with all the drug companies. None of them wanted to provide even drug for the study because their drugs are coming off patent in a few years, and they didn't see it as a market that was big enough to make it worth their while. But we can get abemaciclib through CTEP with a null hypothesis that we would increase relapse-free survival, essentially doubling it. We could do a single-arm study with only 23 patients. So, that was something to consider. This was kind of the schema that we put together, but I think there are certainly other, ways to do this study. And I thought if we had any time, we could chat about it. There were several issues that were brought up in discussion. Of course, a lot of medical oncologists want us to do a study in advanced disease. But my feeling is that the cleanest way to understand the impact is to start with patients who all are at the same place, no visible disease after surgery. And that a drug like this is a great drug for the adjuvant setting because it's so well tolerated. It's kind of similar to thinking about, the way we used the drugs in the adjuvant setting to treat GIST. And so imatinib's, registration done in that way, very similar, well tolerated oral drug, et cetera. So so I think that the realistic ways to do this trial would either be as a single arm, which is obviously always a little bit less convincing, but I think with a big hazard ratio, it would be pretty convincing. The other way would be to do a randomized trial, maybe using a 2-to-1 design. Obviously, the concern about randomization is always patients not wanting to enroll, but a 2-to-1 design would certainly encourage enrollment. We can't really do a placebo control arm because there's no money to fund a placebo. Making placebos are incredibly expensive. And so again, adopted, the idea from the GIST experience. I think you could talk about, how long therapy. I thought, 3 years, given the GIST experience, was reasonable, but we could talk about 1 year, 2 years, et cetera. We certainly want to be beyond the median relapse-free time, which is a little over a year. Obviously, there's no competing studies, and I think that there's lots of centers that would be enthusiastic because we all have these patients, and with a small number of patients, I think we could do this trial fairly rapidly. So I want to acknowledge all the people in my lab who did this work, as well as Shumei Kato, who's a medical oncologist at UCSD, who is the PI of PREDICT and enrolled most of the patients. His fellow Daisuke Nishizaki, who put a lot of the clinical data together. And we had funding from the National Organization of Rare Diseases, as well as a grant from the NCI that supported this work. So I'll stop there and glad to take questions. And
Questions for Dr. Lowy?
yeah.
Yeah, because there are people on Zoom, so they can't hear you unless you're on the mic.
No, it's impressive, the responses that we have seen with palbociclib and the fact that these are GNAS mutated colon cancer. I have just one question and a comment. And the question is, in terms of the GNAS mutation, of course, it's quite common in appendix mucinous adenocarcinomas. But we are also dealing with mucinous colon adenocarcinomas, which tend not to respond very well to systemic therapy. Do you have plans to say, regardless of the presence of GNAS mutation in mucinous adenocarcinoma, because of the MUC4/5 pathway, maybe palbociclib might have some efficacy in that group too? Or do you have plans to test that group?
So we have preclinically, and they don't respond in the same way. And that's the thing that, biologically, we think they're different tumors, they're different pathways. And if you look at a lot of the genomics of mucinous non-GNAS mutant colon cancer, they look a bit more like garden variety colon cancers. They have, and it's purely a hypothesis, but my hypothesis about why these tumors respond is I think that, they don't have tumor suppressor gene mutations that disrupt the checkpoint. They don't have P53 or CDKN2A, or many of these mutations. And they're oncogene, they tend to be oncogene driven tumors. And so I think it's easier to kind of put the brakes on them because they haven't lost the brakes. So that's hypothesis, but we have looked at several mucinous non-GNAS mutant colon cancers in the preclinical space, and they don't respond the same. And whereas we had one GNAS mutant colon cancer, and it responds just like the appendix cancer. So that's but that said, there is more to this that we don't understand, because I can tell you, we've looked at a lot of pancreas cancers, and we see the occasional pancreas cancer, which responds really well to palbociclib, despite having a RAS P53 mutation. And we don't know why. We have a systems biologist, Trey Eidecker at UCSD, who's very, very well known. And he has developed this neural network to look at palbociclib responsiveness actually for breast cancer. He has like 200 cell lines of breast cancer. They put through all this modeling, and they've come up with about 12 different nodes of protein associations, which predict with very high power the likelihood of response. And so we're actually working with him. We actually just wrote a grant to do this for pancreas cancer, to try to see if we can find biomarkers for pancreas cancers that might respond to palbociclib. And so you could theoretically do that with, probably any tumor type. But there's a lot that's, people have been working on biomarkers for palbociclib for breast cancer since these drugs were conceived. And aside from hormone receptor positivity, we still don't understand it. So it's not as simple as everyone kind of thinks it should be.
So the predictive marker could be beyond just GNAS mutation, is what you're saying.
Yeah, what I'm saying is we think that this is a fairly good predictive marker. The co-occurrence of KRAS and GNS. And you saw not every single patient responded, but but 80% did. And just for perspective, the recent published study from Andrea Sarek at Memorial, they look back at their CEA responses to chemotherapy, and only 14% of patients had a 10% or more decline in CEA on systemic cytotoxic chemotherapy. So it really puts that data, it really makes the data look even better. So there's something unique about the KRAS GNS co-mutation, but beyond that, yeah, we don't understand very much.
And thank you. That's very helpful. With the trial design, the randomized concept, which seems to be probably the more appropriate one, is to randomize it to patients who just get height reduction followed by the
Right.
You don't see them again.
Yep.
Compared to that adjuvant palbociclib.
Yep.
In that group, are you thinking about just mucinous adenocarcinoma, the serotonin carcinoma?
Yeah, the way
right,
it's a good question. The way I conceived it was to have everyone have low grade, just to make it very uniform. I didn't go over it, but on this study, about 2/3 of the patients had low grade mucinous carcinomatosis peritonei. About a quarter of them had high grade, and then a quarter of them had mucinous adenocarcinoma. So it's not just we didn't just see responses in low grade patients, but I think, for a trial design, it's a good discussion point, and I definitely want to hear everyone's opinion about it. So whether we should include all grades as long as you have the mutational, the mutational profile or so. But the way I initially conceived it was to make it as uniform as possible was mucinous carcinomatosis peritonei low grade, because those are the ones that have the highest incidence of that co-alteration.
Okay.
Yeah.
No, that's just very nice.
And I think there's enough patients, nationwide to do a study like this.
I would think so,
Yeah.
with the concept that you're proposing 2:1 randomization, I think it certainly is feasible with so many people interested in this.
Thanks.
Dr. Bierman, did you have a question?
Andy, that's amazing work, and congratulations on getting all that done, kind of starting in the pandemic.
Yeah.
And my question kind of related to the modeling using slide culture, things like that. In a study like this, it seems like a perfect opportunity to get those tumor samples and do the in vitro lab work for all of the patients, and then ultimately see whether it reflects what happens down.
Yeah, I think, it's challenging if you do a study through SWOG to get viable tissue, but it's certainly, we would try to do at least a fraction of them. I think, it's feasible.
I mean, it's a small
It's small. Yeah, I think we could talk about it. I definitely, look to your input about this because you've been doing slice culture longer than I have.
Yeah,
So,
it kind of works
so,
if you,
yeah.
You can
Right.
transport them.
Yep.
It's not as
Yep.
perfect, but it's probably.
Yeah,
it's
I
worth doing.
I definitely think, obviously, if we didn't do correlative science, we'd be missing the boat on
Missing a lot.
learning a lot from
Yeah,
this study. Yeah,
Yeah, cool.
absolutely. Yeah.
Yeah, go ahead.
Yeah, really fantastic work, Dr. Davis. Question I have is, some of these patients have an indolent course even post-op after recurrences.
Yeah.
Any thought on starting the trial at the point of first recurrence rather than giving adjuvant to everybody? Because it'll
Yeah,
definitely signal.
it's an interesting thought. Again, it just becomes, it's a little bit harder to then what's your endpoint, and you can say it's progression, but progression, again, it's either you have to make a CEA definition or, a symptomatic definition. It just gets a little bit more, I think, complicated as far as endpoint. But the point is well taken. The thing about it to me is that the drug is so well tolerated that, I've never, given patients a cancer drug who tolerate it as well as this. And so they really have very few to any side effects. And so I think the concept of remaining disease-free and being on the drug, indefinitely, I think is, it's kind of like a imatinib, it's like the patients can stay on it for decades and it's actually less toxic than imatinib.
So for imatinib too, we would select high-risk patients for adjuvant therapy, so.
Yeah, well, this is high risk because, I mean, we're starting out with, that's why we chose the PCI score of being so high. Because we know that those patients mostly recur and they recur pretty rapidly. So, yeah, it's not all comers, not the people who have a low PCI and mostly just mucin.
Yeah.
Yeah, it wouldn't be those folks because then it would take too long to get an answer. So that's why we use the database to kind of look and figure out who would be the right group. And that obviously also limits the patients. So it makes it a little bit more challenging to accrue, but which is why we try to keep the N really small.
My vote will be for randomization.
Yeah, I think it's better. We'd have to get the numbers. I didn't have to kind of run those numbers, but I'm guessing it'll probably be somewhere around 50. Yeah.
Dr. Gulami, do you have a question?
I have a question. So for those patients that you said were on like 8 years, do you see imaging evidence of, or is it just the CDA?
We rarely see imaging evidence of regression. Remember, the other tricky that this is a cytostatic drug. It's not a cytotoxic drug. So you don't really expect regression. The one patient who a little bit of regression was called was actually the pancreas cancer patient. And that's almost my favorite patient of this whole story, because that really, to me, gave proof to the fact that this is based on the biology and the genetics, because totally different, it's, organ site of origin, but same genetics. And yet that patient actually is Andrew Koch, from UCSF's patient. He put her on FOLFIRINOX. She couldn't tolerate it. And she came looking for something. She actually came to me to operate on her to see if I would do a cytoreduction on her, because she had, mucinous adenocarcinoma, carcinomatosis. And I said, that doesn't make any sense. But I said, you have the same, they had profiled her and she was KRAS GNS mutant. I said, you have the same genetics, try this. And we put her on, and her CEA N99 normalized in 3 months on palbociclib. And she's been on it now for 22 months, single agent. So we haven't done that yet, but because we haven't actually reoperated on, most of the patients, if they progress, they're already not great surgical candidates, which is why they're on the drug. But if somebody, I assume someone will present with a bowel obstruction or something at some point. And so it's a great question, and it's certainly of interest to see what things look like. Yeah, thanks.
Any couple quick questions. So have you done any preclinical work with the second CDK4 inhibitor that you're proposing in the study?
We've used all the drugs. They all work.
They all work.
They all work. They all work very similarly.
Is there any date? And so have you looked at the patients who respond and don't respond in terms of different types of KRAS mutations? I mean,
yeah, we haven't done that. It's an interesting question. Appendix cancer actually has the highest rate of G12D mutations of any tumor type. 50% of appendix is G12D mutant. And so most of them are G12D, but the numbers obviously are really small. It's only 16 patients. The interesting thing is that there's one patient, and I didn't point it out because of time, but there's one patient in the study who has an RB mutation, which is a mutation that if you know the biology, you'd say they should never be able to respond. There's no possible way, and they did. And so it just points out that there's a lot we don't understand about this pathway. Because if you could pick out one alteration that you would say should prevent response, it would be that one. And yet that patient responded. So it's really complicated. So we're really interested in Trey's neural network work to see what we could learn.
I mean, I would be excited to develop this in SWOG, and I think there'd be a lot of enthusiasm.
Yeah, no, absolutely. That's our plan. I didn't move forward with, developing the trial further because I thought that when it got to the upper level committees, in the absence of a publication beyond a single patient case report, that it might not move anywhere. So our paper's in review right now. And once I get the sense that it's going to get published, I think then we'll restart the clock, because I think then it'll have a much better chance of moving through pretty quickly. So,
Thank you.
Yeah,
That was
yeah.
fantastic. Our next speaker is Dr. Maggie Senthil, professor of surgery at UC Irvine. She's going to be giving us an update on the POETIC study. We've heard and been involved with the development of the study. I think we're finally getting a point where that's hopefully some exciting news soon.
Well, thanks again for the opportunity, Sai. I mean, obviously, many of you have heard this concept many, many times. I'm just going to give you a quick update about some of the additional things that we have to present at this point. Smita and I are leading this study. We've been working on it for almost 3 years. Neoadjuvant immunotherapy has activity in proficient mismatch repair colon cancer. Now it's irrefutable. We have data on this, and the rate of major pathologic response in patients with proficient colon cancer, proficient mismatch repair colon cancer, as you can see here, is about 30% pathologic response. 7 out of the 9 patients who had major pathologic response had major pathologic response in the niche study. So 23% major pathologic response in proficient mismatch repair colon cancer with just a single dose of ipilimumab and 2 doses of nivolumab. So there is efficacy here in proficient mismatch, and hence the hypothesis has always been there's a combination CTLA-4 and anti-PD-1 treatment combined with chemotherapy will result in a higher rate of tumor regression. So that has been our primary hypothesis to move this forward. And this study design has gone through multiple iterations and changes. And here is we hope, a final design that might go through a capsule submission at this point. And now it is a smaller phase 2 randomized control trial of proficient mismatch repair colon cancer randomized to either immunotherapy or immunotherapy with chemotherapy combination. The eligibility of patients would be T3, any node positive colon cancer, or clinical T4 and NEN. So it's either node positive T3 or T4 NEN proficient mismatch repair colon cancer. The clinical staging will be done by radiology. And after, as you can see in the trial schema, after that 6 weeks of treatment, patients do get 3 doses of Folfox combined with ipi/nivo in the chemoimmuno arm, and they undergo surgical resection for the colon cancer. The primary endpoint is tumor regression score, 0 to 1, will be ascertained by central path review. And here is how we are thinking about in terms of the statistical plan for this smaller study with the primary endpoint of tumor regression. We have looked at the major pathologic response in Foxtrot study, as well as a niche study. 23% in niche, Foxtrot is about 8%. So our expectation is that we will see at least 25% tumor regression of 0 to 1 with neoadjuvant immunotherapy or neoadjuvant immunotherapy chemotherapy combination. This would be a Simon 2-stage design, and the number of patients needed per arm is about 40. So it's a smaller study, 80 patients. The first stage stop would be at 20 patients per arm, looking for tumor regression of at least 1 by that time to move that arm through. And we also are looking for safety with this regimen. And there will be no formal statistical comparison of the 2 arms planned. Now, the biggest question that was posed to us when we were proposing this concept is how confidently can you stage these patients with just CT? And thus, we have completed an CT staging study at UCI. This was a blinded study. The radiologist was blinded to the histopathological staging of patients who underwent primary resection for stage 1 to 3 colon cancer. Tumor and nodal stage were documented by the radiologist, which is the clinical T and N stage. And we compared it to the pathologic T and N stage, and subgroup analysis was done comparing proficient to deficient mismatch repair colon cancer patients. I just want to share this data because this is going to be the key for any neoadjuvant colon cancer studies, particularly since overstaging is a concern in this area. So the tumor characteristics of the group, we had about 80% of patients who had T3, T4 disease, and 45% had node positive disease. And we also had about 80% proficient mismatch repair of colon cancer. So we had a fair representation of the group that we were interested in studying. Next slide. So in terms of radiologic staging, here is the entire cohort's overstaging rate for T3, T4. The overstaging rate for the entire cohort was about 8.3%. And then for proficient mismatch repair is about 6.8%. And for deficient, it was a little bit higher, but it's smaller numbers. But we were, for the purposes of the study, we are interested in proficient mismatch repair colon cancer. So again, for the T staging, we had a very reasonable overstaging rate of about 6.8%. It is certainly comparable to the previously published neoadjuvant chemotherapy trials in colon cancer, Foxtrot article and NeoCall, 6.8% in our study, 6% in the Foxtrot study. The next point was the radiographic nodal criteria, which is also in fact, that was the area of concern, is that how accurately can we stage nodal positivity with CT. So we used 5 criteria or 5 features that have been shown to be associated with node positivity. Those are listed here, and these are the 5 features we looked at. And when we looked at the presence of any one of these 5 features, the overstaging rate for the entire cohort was about 16.5%, and for proficient mismatch, it was 13.6%. Sensitivity and specificity ranged from 50 and to 66%, but the specificity was about 72%. In order to further improve the overstaging rate, we sought to use a combination of features. In this slide, I'm just showing the overstaging rate for each and every one of the individual features, along with sensitivity and specificity. And in terms of the combination features, which comes in the next slide, the 5-feature composite, which is the presence of any one of these features when present, had an overstaging rate of about 14.8% in the proficient mismatch repair group. However, when we eliminated some of these features, particularly the size as well as the number of positive lymph nodes, just using irregular borders, heterogeneous enhancement, and EMDI as the 3 features, the overstaging rate for nodal positivity was about 8% in the proficient mismatch repair. When we looked at the size as well as the number of nodes, because our leadership really wanted to have some simplistic criteria to identify node positivity, for the proficient mismatch repair, even with those 2 features, the overstaging rate was about 9.1%. So we feel that with this particular analysis, that we can confidently stage patients clinically using CT staging, both for TNN staging, with acceptable overstaging rate. I understand that the sensitivity is lower for the 2 features. However, since we are more concerned about overstaging, that has been our primary driver as to how we put together these features. Now, another update that happened is that I was able to present this with the imaging committee yesterday. They were very supportive of the central review, but also felt that at this point, we can use 4-feature composite for nodal positivity to improve the sensitivity, but still maintain the accuracy. And hence, we are working with the group to develop a training module with the CT scans that we have put together, and also work with the local radiologists who might be participating in this study to train them and be able to do this CT staging upfront. So we are expecting a central imaging review, and I see Dr. Michael Noop here, and thank you for the support, Dr. Noop. And the next steps are, we are working with Dr. Steve Wexner to get support letters from the colorectal surgeons. We are thinking about some of the funding opportunities for the ctDNA, and hopefully, as you heard yesterday from Dr. Philip, we are expected to submit this capsule in about 10 days. And I'm happy to take any questions.
Really exciting, seeing the development of the study and perseverance that both you and Smita have had. Michael, do you want to make a comment first about imaging, difficulty of a study like this, and how your group can kind of help support the study?
Well, let me take a positive spin. Let's say there's a tremendous opportunity to advance and bring these tools into basically the local environments to guide the assessment better. So the reason I'm saying this positive, yes, this is difficult, but it's doable. And I think what we are embracing is now on all the things that we have learned, capitalizing on the electronic environment that IWOC has in place. The central collection is critical for the eventual validation of other things, but we do want to support as much the local sites as possible. And by making some of these tools available that then guide the readers in order to minimize and at the same time capture the data in a way. So all of that is very consistent with the NCI efforts of streamlining clinical trials. It doesn't mean that we do less, and it doesn't mean that we do less complicated things, and so what is really wonderful kind of in this trial development is the engagement, reaching out for the imaging committee. Dr. Schwartz took the leadership, and in our role as IWOG, we are more than happy to support that. And you know, I think this will be a very good example how we kind of bring the new technologies, the tools to manage the complexity and makes this very doable.
I think one of the things I see is opportunities for some translational questions, specifically around imaging. And I would, you know, encourage you to think of those questions ahead of time and really engage with, Michael and IROC and, things like, I don't know, Michael can probably tell you the new technologies coming out that we could utilize to determine node positivity. And, there's certainly opportunities for some translational questions there that can be built in.
Yeah, sorry, but with regards to those, in terms of I'll finish answering that question. Yeah. So there is a lot of opportunity with advanced radiation evaluation using artificial intelligence and convolutional neural network.
Yep.
So that's going to be something that we would be looking for this study. Since we are also getting the pre-surgical or pre-treatment scan, and with the imaging committee's recommendation, a pre-surgical scan. So we will have both pre and post-treatment scans, which would be very helpful to kind of look at some of these technologies.
Yep. And I would remind you that there's some opportunities within the HOPE pilot funding, in terms of getting some support for, some of these questions.
Yeah.
Dr. Lowy?
Yeah, very nice. So I had a question. You presented the data about the T stage and the N stage independently, but I suspect the data is actually better in that there's overlap, so that it doesn't matter what the nodal stage looks like if the T stage is very clear and vice versa.
Yeah.
So that the amount of overstaging should probably be even less than what you presented.
Great point. Great point.
The other question I had, just practically, certainly in the community still, PET scans are used ubiquitously, and many patients have a PET scan in hand before they see any of us. So I'm wondering how you were thinking about incorporating PET scan results. If that's positive, if that will that be an acceptable enrollment criteria, or what your thoughts are about that?
So for the purposes of the study, contrast enhanced CT imaging is what we would be looking for in terms of the staging. So that is a requirement for the study, that they should have contrast enhanced CT. All of these evaluations was done on contrast enhanced CT. If a patient has PET and there is conflicting results between the PET and what we see on CT, and that's where the central review is going to come in handy to be able to reconcile some of these differences between different imaging modalities. And we will make the final decision based on image enhanced or contrast enhanced imaging. In terms of your point about when combined CT and nodal staging, would your overstaging rate be even lower? That's a very likely possibility. The reason why I chose to present it as two separate groups is that since the concern has always been, will we end up over treating patients who are node negative disease in the setting? Because node negative disease in the setting of T3 is what we are concerned about. We are not concerned about node negative disease in the setting of T4. So when combined, I think our overstaging rate would be even lower. I will use that point to justify further. Thank you. Any other questions?
Great presentation.
Thank you.
Our next presentation is Dr. Mustafa Rove from the City of Hope, talking about PIPAC in second-line treatment of colorectal cancer. Another exciting concept. Mustafa has presented this during our monthly surgical conferences, and he'll give us an update on where things stand with this concept.
Yeah, thank you to the co-chairs for the opportunity to present this concept. So I have the listed disclosures.
Point it up there.
Oh, okay.
Yeah.
All right. So as we know, I think the group is familiar that peritoneal metastases have worse survival compared to other sites of metastases, and that was shown a number of years ago. And I think even with contemporary chemotherapy, we know that cytoreductive surgery with perioperative chemotherapy has produced the best results we've seen in this cohort of patients, with about median survival of 41 months. We also know that majority of patients are not really candidates for cytoreductive surgery. You have a disease that is too advanced or involves critical areas, for example, small intestine, where we cannot perform cytoreductive surgery. And most of these patients are not really cured with cytoreductive surgery. Relapse rates are, 80% or higher, even with complete cytoreduction. So progression of peritoneal metastases is problematic because it worsens quality of life, increases hospitalization, reduces treatment tolerability, and limits survival. So this is the rationale for a regional approach combined with a systemic approach. So this is PIPEC. So PIPEC is the new kid on the block. It's about 10 years old now. And this is injection or aerosolization of chemotherapy to optimally deliver chemotherapy laparoscopically. And the good thing about PIPEC is that, it is an ambulatory procedure. Patients can go home the same day or the next day. And it takes about, a couple of hours to do with research biopsies and everything. And, it's fairly well tolerated. So some of the advantages were summarized in this publication from 2019. This is multiple cohorts were combined, mostly patients who have refractory cancers and multiple different GI cancer types. And based on some loose definitions, they had encouraging clinical responses in earlier studies. So, but it certainly builds the rationale for further study. So we were kind of late in the US to catch on to this potential treatment. And so we started this trial back in 2020. And at that time, we had 2 arms to the study. And we just essentially wanted to reproduce the European experience. So we did not escalate the dosages. We stuck with what was published. And this trial has now been published. The arm 2 of the trial has been published, where we show that in refractory setting, there's good disease stability, and at least preliminarily, there's some advantages in good days outcome as well as overall survival outcome compared to historical cohort. So this I presented a concept based on this study in refractory setting with the palliative and end-of-life committee on Thursday. And so the concept I'm presenting today is an earlier line setting, which was prompted by our findings in the refractory setting, that we were finding stable disease but not really responses in this setting, which is a tough benchmark to achieve anyways in peritoneal disease. But also a lot of patients are already refractory to oxaliplatin. So that prompted us to look at mitomycin C as an alternative because it has some track record for intraperitoneal delivery. And this was the next logical step. So in this setting, this was the key eligibility for this trial. We included colorectal and appendiceal peritoneal metastases. We include patients who are not candidates for upfront resection. And these are most of these patients have small bowel disease, which excludes them for predicted CC0 cytoreduction. We limited to patients who had no extraperitoneal metastases to select for biology. And we also made sure that these patients had received at least 4 months of first or second line standard of care chemotherapy. Obviously, patients had to be in good performance status and not refractory to irinotecan, because irinotecan is the combined systemic cytotoxic therapy that we use in this trial. So the patients were getting PIPEC every 6 weeks, and in between, when they're not getting PIPECs every 2 weeks, they would get FOLFIRI. We did not allow for Avastin because of safety concerns with laparoscopy, although some groups have now published that is somewhat safe to do. So this is the dose escalation regimen. There are 4 dose levels, escalating up to 25 milligram per meter square, which was shown by the Dutch in their dose escalation trial of PIPEC to be a safe dose. But this is indwelling, so we expect lower dose to be safer. And there's a bunch of translational correlatives that we will be doing. So this is a combined effort with 3 different centers: Northwell, Mayo Clinic, Jacksonville, and City of Hope. And so far, an update on this trial: we've accrued 13 patients to this trial, and the demographics are listed. 3 patients enrolled on dose level 3. On dose level 2, we had a couple of issues. One, there was a supply chain issue with the nebulizers. And so some of the patients had to come off of treatment, unfortunately. And so we had to restart the dose level. Another issue that happened at that time was that one patient developed a grade 3 ileus, which was not during the DLT period. It was not during the first 6 weeks. So we wanted to learn more about this therapy because we are doing cumulative intraperitoneal therapy. So we expanded the dose level. And we were pleased to learn that there were no further grade 3 adverse events of this combination. We were worried about hematologic toxicities, but that has not been the concern. Most of the hematologic toxicities have been grade 1 or grade 2, but no severe hematologic toxicities have been seen. And so we have now enrolled 2 patients on dose level 3. So in terms of toxicity, let me go back. So in terms of preliminary efficacy data, 9 patients were eligible for efficacy analysis. Those are the patients who were not taken off the study. Most of these patients completed, 3 PIPEX, almost all of them. And this is responses based on PCI and histologic scoring. So in dose level 1 and 2, we see that there's steady decline in PCI with subsequent PIPEX. And same with histologic regression grade, less is better. So 0 means no disease, 1 means some epithelial cells, mostly fibrosis. And we can see some response, which we were not seeing with refractory trial. And in terms of radiographic assessment, so patients who have non-measurable disease who stay non-measurable are classified as stable disease. And so in that, we have 7 patients who have stable disease. We have 1 patient who had complete response and 1 patient who had partial response. So I think it's too early to report out the survival data, but I put this together just to get a sense, because anecdotally, last time I presented, we were seeing some responses, but it wasn't tabulated. So with this, this is the proposed design for the trial that I'm proposing that we conduct through SWOG. So it has a very similar inclusion-exclusion criteria. There's some differences in that we don't want patients to be on FOLFIRI chemotherapy for a long time before we enroll, which is allowed on the current phase 1. So this is the criteria listed. So basically histologically confirmed colorectal cancer peritoneal metastases. We are excluding appendiceal cancer from this proposed design because that had been the criticism of the previous trials. For example, the VIRWAL trial that was published in early 2000s was that 25% of patients were appendiceal. Hard to make head and tails of the efficacy. So we're restricting to colorectal cancer. We're saying no prior irinotecan therapy. They should have completed 8 cycles of FOLFOX. We are allowing patients who are progressing on FOLFOX to be on the trial. And the key is that they should only have peritoneal disease. And the reason we're doing that is because we are combining FOLFIRI and mitomycin C, which are different cytotoxic agents. But the plan is for a stratified analysis based on whether or not they're progressing on FOLFOX. Patients are allowed to have some lung lesions that are small because those are rarely the lifespan determining lesions, and it creates some ambiguity in terms of enrollment, and could be a reason for patients not included on a trial. The other standard criteria are listed. And so this is a 2-to-1 randomization. We want to incentivize patient participation. My fear is that off-label use of PIPEC will become popular like it has for HIPEC. So there is a little bit of an urgency to do this trial because the longer we wait, we will lose this opportunity to study this modality, which has some promise. And so the 2 arms are listed there. And then primary outcome is progression-free survival because it allows for a smaller sample size. And I think it is meaningful. We have shown that in the refractory setting, that if you have resist progression, it correlates with overall survival. That was a smaller study. But we went back and looked at our patients who had cytoreductive surgery from the HIPEC collaborative and international collaborative. And it seems like unlike liver metastases and peritoneal progression or overall progression does correlate with survival. So, I think there's a good rationale to use PFS as an endpoint for this. There are a bunch of secondary endpoints that are listed. We have an optional laparoscopy at 24 weeks to understand if those patients could be candidates for surgery at that point. And there are some exploratory biomarkers which haven't been developed yet, but I think others will be interested in looking at that too. So this is the sample size calculation from our statistician. And we're going with the second statement, but folks can read this. And so estimated completion time will be 3 to 4 years. Thank you.
Great presentation. Questions?
Mustafa, really great job and congratulations on all the progress you made here. I guess my question is, why not do this as upfront treatment naive patients? My concern is hazard ratio of 0.6 in the refractory setting has almost never been achieved by any drug in colon cancer. You look at the registration trials for bevacizumab and all, they don't get that kind of hazard ratio. And the amount of patients that were needed in those trials was enormous. So I just think, I mean, to me, biologically, when these tumors become resistant to cytotoxic drugs, they're generally pan-resistant to almost everything. In their single agent response rates to irinotecan is 10% in refractory patients. So it's just such a hard thing, that EMT, they all become mesenchymal and they don't respond to anything. It's just such a high bar. And we don't have anything to treat these patients up front except cytotoxic therapy, which we know works for only a short amount of time. And so the best thing is to get them to a place where they can have a cytoreduction, or obviously, ideally, have the drugs eliminate the disease. So I guess given that it's safe, that you really been proving that it's safe with your trials, to me, why not do it in the initial, as part of initial therapy? And I think you just have a better chance of making impact and maybe seeing something. So I guess that's my question.
I think fair point. I think that's a really great suggestion. Having thought about that previously, a couple of reasons that we wanted to wait for induction chemotherapy was to select for biology. And, some patients, as 20% will met out very quickly. And to exclude those patients is why we, impose that restriction. The other reason is logistics. Many patients in the heat of early diagnosis, they just want to get on therapy. And the 4-month induction period allows patients to actually find the trial.
Right, I guess my point is, I wouldn't include people who have progressed. Is if you just keep it to people who haven't progressed, then you have a more uniform group and you have a better patient group biologically. I think by introducing people who have progression, you're, to me, shooting yourself in the foot because you're going to make it's a confounder, and it's also much higher bar to get over with respect to, biologically.
Yeah, absolutely. I think, that point is up for debate. And, I think you make a fair point about excluding those patients who are progressing on FOLFOX. I thought you meant starting PIPEC off the bat.
Yeah, no, I mean, just not having patients who already failed therapy. Because I just think it's, it's really, I agree, challenging. Right? What I think is interesting about this technology is obviously the potential to use other drugs, not cytotoxic drugs, but other more innovative drugs. And so I wonder if you have any ideas or had any conversations about any agents in that space, because that's where I think it could get really interesting.
So in terms of that, I think the decision that I had to make about this mitomycin C was because obviously our drugs are very old and we really need novel therapies. The question was, do we want to push a regional therapy trial in this space with suboptimal drugs, or do we wait for better drugs? One of the reasons that got me excited about mitomycin C as opposed to oxaliplatin is that mitomycin C causes intense fibrosis. It's not to the degree that we're seeing effect on quality of life, but it changes the tumor microenvironment significantly. So I think mitomycin C, beyond its role in, anti-proliferative and DNA damaging effects, is causing other things too. And I think that is part of the reason why we're seeing good results in our preliminary efficacy analysis. So I think with those results, it seems appropriate to push this trial. But if it is a negative trial, it will be a negative trial of PIPEC with mitomycin C, not the conduit, not the delivery device, or not the delivery method. So what are we investigating other than that? Preclinically, multiple things, but we have another biliary cancer trial that is using Abraxane, which is a nanoparticle formulation. So, there's plethora of things you can use. In Europe, they've been giving, DNA-based, RNA-based therapeutics in addition. So yeah, there's a lot of opportunity here.
How are you measuring response when you look primary endpoint progression-free survival? So how is that being measured?
Progression-free survival will be measured through RECIST 1.1. The issue with these patients is that, yes, the actual response with RECIST definition is difficult because you can, but when they progress, that progression on RECIST criteria is actually correlating with survival. So it is a little delayed, yes, but still, it is still better than overall survival in terms of the sample size.
Okay, I think it's going to be hard to measure. You'll have stability of disease in the majority of patients and won't know whether you're actually having a response or not. As kind of Andy pointed out in his talk, these patients are really hard to image. Yeah. Great. Yeah, fantastic talk. Thank you.
Thank you.
So Dr. Kalami will be presenting a study that she's developing through the CTP network, investigation of immune-mediated changes induced by tiragolumab. Did I say that right? Atezo plus chemo in the tumor microenvironment of colorectal liver metastasis. Co-developed with SMIPA as well.
Thank you. Yeah, I should make the title shorter.
Tiragolumab. How do you say that?
Tiragolumab. So thank you for allowing me to present this. I apologize for those who've already heard this yesterday, so it's a little bit repetitive, but I appreciate any new thoughts from any new members who haven't listened to this already. So I think the background for this is that I've been working on just trying to come up with like new novel really strategies for, dealing with patients with colorectal liver metastases. It's been sort of drug development that's sort of the core of my heart. And so as you can see in the background is that we really don't have anything new outside outside of perioperative, the generic chemotherapeutics with baseline being FOLFOX. And it hasn't really changed for several decades now. Despite the lack of OS benefit, we still use it and we still see greater than recurrence rates of over 70%. And so I think like really studying like immunoregulation in that space in the TME of liver metastases is really needed to inform us about sort of immune-mediated treatment strategies for these patients. With regards to why a neoadjuvant approach is that we've seen in other examples by Dr. Sursik's study that was presented with like almost like 2 years ago now. It showed that there was like 100% response rates in MSI high rectal tumors when they were like early treated. We've also seen in other examples using immunotherapy as neoadjuvant approaches, even in the MSS static setting, compared to like the very advanced setting, as Dr. Lowe was already alluding to. So it's like the later you treat, it appears that we really see like worse responses. So this was seen in the niche study with 27% of showing pathologic responses, and even in a different study, the Nicole study, you see like higher immune infiltration in the earlier stage patients, stage 0 to 2, compared to stage 3 patients, and even those with higher immune scores, in the control group. So I think all of this emphasizes, we need higher cure rates. We need to make colon and rectal cancer more immunogenic, especially focusing on the MSS population and develop newly targeted therapies or combination therapies. With regards to like what have we seen in the neoadjuvant settings in terms of responses so far in MSS colorectal cancer is that we know in preclinical models and a CT26 colorectal model, which again, these are not great models that we've seen with the use of FOLFOX. You see increase of CD8 TILD infiltration, you would see interferon gamma secretion, as well as like depletion of MDSCs and induction of sort of like increased PD-L1 expression on these tumor cells. Furthermore, in patients who are treated with FOLFOX, you can see again the CD8 tumor cell infiltration and PD-L1 expression in those specimens. And this is from the Idea de France study in patients who received oxaliplatin. When they looked back, the Galan group really who came up and created the immunoscore saw that the patients with a higher immunoscore, had higher response rates compared to those with, the shorter ones of FOLFOX treatment. So, and also the duration of chemotherapy in that study was actually irrelevant with regards to those who, had lower immune scores. So treating more is not necessarily beneficial. With regards to this concept, we're using atezo as our combination with immunotherapy. And why that? Well, one is that Genentech was really interested in this combination as to trying to understand mechanistically what's going on, which is really what, my research focus has been. And furthermore, they just published that atezo with FOLFIRI Bev has shown some increased PFS in patients with the metastatic, again, very advanced setting. So they have a new agent that targets TIGIT. So TIGIT is an immune checkpoint molecule which inhibits T cell activation. It does so by two distinct mechanisms. One is a direct inhibition, and two is like an inhibition of a co-stimulated AC226 signaling. And when TIGIT has been in the clinical setting, so far it's been published using with atezo in patients with sort of chemotherapy naive PD-1 positive recurrent metastatic non-small cell cancers. I haven't seen any other publications in other diseases, but there's been other studies that are ongoing. And there's been some increase of the PFS as well as the response rate reported in those with the combination. This is the study that I was moved into, and Dr. Faki presented as a sort of the colon updates was that atezo in combination with FOLFOXIRI and Bev in the metastatic advanced setting has shown some, increased benefits with regards to the PFS. And then in those patients with a high immune score, there is a marked increase in the PFS as to those and the overall survival. So I think for, the my lab really are focusing on really studying like sort of the TME and looking at immune resistance and responses and how can we really create a rationale for better combination therapies. And I think really the opportunity to have pre and post surgical specimens is really like the best setting. And I think with regards to liver mets, it really is just one of those settings where we actually operate in a metastatic setting and it makes sense to do so. So to me, it seems like a no-brainer to use this as and leverage this setting. So the current schema, and this has been sort of gone through multiple iterations, is that patients who are resectable with liver limited disease only, who are excluding the BRAF V600E patients will be randomized to two groups. One is standard chemotherapy, that's FOLFOX plus atezo for 6 cycles versus FOLFOX 6 cycles of atezo and Tara. And then they will be just reassessed with cross-sectional imaging, blood and blood samples, and then undergo their liver resection within like 4 to 6 weeks, just to give us some room here for in terms of the trial setting, a typical like the curative intent liver resection that is already in plan. We will allow for patients to also have ablative therapies in this. So really just don't want to change any of the surgeon's treatment plan. We will also collect serial ctDNA assays from the beginning and to the study to really study the dynamics. So that we've gone back and forth a lot about the endpoints, and the sort of final decision has been to focus on tumor regression rate, which has been well published in patients with liver metastases. Secondary now endpoints are going to be response rates, R0 resection, perioperative safety, morbidity, as well as PFS. And then the exploratory are really where I think the focus of this study is looking at the tumor microenvironment profiling, the ctDNA kinetics, as I mentioned, and then really correlating that to the path responses to really leverage that for and get enough information for the next clinical trial. With regards to the sample study size and analysis, we've decided now on this is going to be a 2. Essentially, given the primary endpoint, focusing on tumor regression score, those, we will focus on those who will have a regression score of 1 to 3. In historical data, if you go back, that's roughly around 30% from the best data I can retrospectively gather. So I don't have the regression scores on those who've had atezo. So given that we had a lot of back and forth and came up with about 40 to 50% in the control arm, and then having about a 20% increase in that response rate. in the arm with obviously the combination therapy. So these are not comparative. This is a pilot study, so they're just going to be independently evaluated, but we're going to consider it positive if, they fall within these parameters and position of the confidence intervals. And with that, the end of it.
So it's kind of like a pick the winner design.
A little bit,
Because
it's
you're
like
comparing each arm individually to historic.
historical,
Yeah.
kind of, but I guess the statistics, I'm not sure if it's the statistics of
Well, it's
the
kind of-
winner.
yeah, if you're-
Yeah, I mean, I think conceptually, but in terms of the actual stuff, I mean, these are really just confidence intervals without actual comparisons, but
So
yeah.
hopefully, this will be a positive study in the TIGIT inhibitor will show activity. But let's say that it doesn't and they're equivalent. How do you know the response that you get is from chemo or from the addition of atezo?
I think, honestly, if this is negative, which I'm not very certain if this is gonna be positive, and I'm okay with that. Like, I think I'm going in with the expectation that if this is positive, then, we're probably very lucky, to be honest, because I'm not sure if we can see those response rates, as expected. But I think that the interesting part will be to really looking at the differences between those specimens and then really mechanistically trying to hone in as to what should we target better and what would be the rationale for better combinations. I personally wanted to have a control arm where you have just atezo.
Right.
I think we will be able to get samples. I've been talking to Genentech to try to get some samples from other patients who've been now, it's not exactly the same population, they're more advanced, but that is something that, I mean, if funding wasn't an issue and I could have 4 arms, I would have all the samples possible, but I think that's going to be a little bit of a limitation.
It's a great concept, and I think we'll learn a lot as this trial accrues and completes.
What's
Andy?
the biologic signal that they are interested in? The relationship between PD-1 and VEGF? I mean, what is it why are they interested? What is it? You said that scientifically they're interested. So what is
I
it?
wish that they have not actually talked about it at all. I think it's I don't know, to be very transparent. Like, in fact, when I've met with the translational team, I couldn't gather, because that's where I was going. Like, what are we really getting at and what specific pathways
I
and stuff?
assume Genentech's going to have access to these tissues.
Yes,
Yeah.
yes. Although we haven't, going to the CTP, it's unclear to me. I'm still trying to learn. We're like at the very beginning of this, like, the way it's written right now in this short proposal is that the specimens are going to come to Cold Spring and we will take care of it in terms of all the analyses. So I have really no idea what will happen between, like, I don't know, you may honestly have a lot more experience with that, like, because they asked me through the
Well, the
CTP,
reason I
who will
ask is
send
because
it.
if you have scientific interests, then
Yeah.
it's really important to understand who has possession of the data.
Yeah.
Because otherwise you may do the study and not be able to do something.
Yeah.
I think the way the CTP works is that both should have access to the data. It should not exclusively be
Right,
Genentech.
but when you're talking about tissue,
I mean,
Yeah.
But if SWOG has questions that they want to also ask, they should have access to his tissue as well.
Right, but tissue is a limited
Yeah,
resource.
I get it.
That's my only.
Yeah.
But I think the way the CTP was set up was.
I'm not saying you don't want to do it, I'm just saying.
Yeah,
Good
no,
to have
it's,
clarity
Yeah.
at the beginning.
Right. Otherwise, Genentech could just do this on their own. Well, I think coming to.
they're saving
Yeah.
money.
Yeah.
have to learn more about that.
Can you, just for the rest of us who may be not so familiar with CTP, can you tell us how you started working with them? Like, did you go to them? Did they come to you? How did this work?
No, so this was interesting. So CTP came to us, and I think the way that happened is that Genentech was interested in studying this combination and then went to CTP and asked if there were any investigators that were interested in this drug combination. And then Gabby, having known about sort of this neoadjuvant interest of mine and looking for combinations for the past several years, connected me with the Genentech group. I think so far it's been very much, I would say, similar to like going to a pharma with a proposal.
Yep.
Outside of SWOG, it's really like SWOG has really not been involved, and quote unquote, besides obviously having been at all the meetings, but none of the other SWOG related sort of, we haven't gone through any other committees, right? So it's been purely a discussion between, the group, obviously the SWOG leadership and Genentech. We met about 3-4 times now. And then after those 4 times, they asked to submit a proposal. So CTP has a feasibility proposal. I submitted that to like Genentech, and then Genentech reviewed it and now has given us the green light. And now we're at the step where we're at budgeting, and full formalized CTP review will be by the end of the month. So,
Yep.
so
So see,
it's
for
an
those who don't know,
interesting-
CTP is Clinical Trial Partnership. I think it was set up by Kathy Albing.
Correct, yeah.
And really, it utilizes resources. So, when we do studies in the cooperative group, we use the infrastructure that the NCI has given us. Funding from the NCI supports SWOG. The CTP, it allows pharma companies to partner with us, but then they pay for everything. We don't use the NCI infrastructure for running the trials. So it's a partnership. They use the SWOG infrastructure to accrue patients, but they're really funding. They're giving the drugs and they're paying for everything. And we're not utilizing SWOG infrastructure. There's pros and cons. One, it saves us money, but we don't get credit for the patients that we enroll. So when we look at accrual for cooperative groups, SWOG doesn't get credit for the CPP. But there is a financial benefit for the CPP as well, because there is a carry forward. So if there's money to give us that we don't spend, then we get to keep that money. So there's pros and cons in the CPP network that's been set up, but it's very innovative and something that, we hopefully will be utilizing more as we move forward. Thank you, sir.
Thank you, yeah.
All right, we're going to give it a go again with Dr. Sham. Jonathan, can you hear us?
Yes, can you hear me?
Okay, yeah. So I'm assuming we're controlling the slides. So whenever you
Yes.
want us to go to the next slide, just give us a cue and we'll advance the slides.
Perfect.
So Dr. Sham is assistant professor of surgery at the University of Washington. He has developed this through the palliative care committee. Dr. Krause is in the room, who's the chair of that committee. And, Jonathan, one of the things I want to concentrate on is the review you got back from CTEP. If you could maybe, query the audience about specific, not the whole thing, but 2 or 3 questions, and maybe get feedback from the audience.
Absolutely. I'm looking forward to that. And actually, I have that at the last couple slides. So I'll breeze through, just for anyone in the room who may have not seen the proposal. I'll breeze through a couple slides, and then I was hoping most of this could be discussion with the group. So yeah, this is, I guess, so brief update since the spring meeting. We submitted the proposal, which is essentially a phase 3 multicenter randomized trial comparing lanreotide to, nothing for the prevention of postoperative pancreatic fistula. In June, it was approved by the executive committee at SWOG. We have a number now, S2408, and submitted it to and presented it to DCP last month, and literally 2 days ago got the review letter back, and I'll review that. It's co-sponsored by Palliative End of Life Care, Surgery, and GI. And just next slide. Just one quick note. This is the rest of the study team: Catherine Guthrie with stats, Robert Krause is in the room there, Andrea Garcia, who's our program manager, and Valerie Sun, who is our executive liaison. These folks, along with many people in the room, have made this possible. Dr. Ahmad, Roca, Dr. Pilarsetti, Sepp, Robert Krause, and more, who are sitting in there. And I'm sorry I couldn't be there in person. But it takes a village, and they've all made this possible. And just another plug for the Hope Foundation, what Dr. Ahmad was mentioning at the beginning of the meeting. I'm in the 2nd year of a Coltman Fellowship, which has really been transformative in my own career. It's the bosses like it because it's a salary only grant, and it protects 25% of your time, and it's just for salary. So it's really, I would really encourage any junior investigators in the room to apply for it. And it also funds your travel to 2 years of SWOG meetings and an additional national meeting each year. So it's really a huge help early in your career. Next slide, please. So I don't need to go over this in this room. Pancreatic fistula is bad. Lots of bad things happen, and lanreotide, which is a somatostatin analog, may help in its reduction. Next slide. So here's a study schema, very straightforward, randomized 1-to-1, lanreotide to no lanreotide. People get distal pancreatectomies, and then outcomes are measured within 60 days. We think that part of the appeal of the study for sites is essentially that other than the drug administration and 3 quality of life questionnaire administrations, everything's standard of care. There's no extra imaging, no extra labs. And so it's fairly straightforward. The primary endpoint is grade BC pancreatic fistula, so clinically relevant pancreatic fistula. And we chose patients getting distals for either malignant or pre-malignant lesions, including IPMN, MCN, things like that. Next slide. So there's a primary endpoint. A secondary endpoint is just a biochemical leak, which is the old grade A fistula, you may recall. Number of post-op hospital days, 3 quality of life metrics at 3 time points. And thank you to the Palliative End of Life Care Committee for helping develop that plan. And then some exploratory endpoints, including DGE, hemorrhage, and time to adjuvant chemotherapy for those patients who have cancer. Next slide. So we presented DDCP on, late last month. And again, as I mentioned, we just got the review letter back. I'll say just from a broad, after digesting it for a couple of days, I think because there was no surgeon on the symptom control and quality of life steering committee, they had several ad hoc reviewers who are blinded, so I don't know who they are, but they're presumably surgeons. And after reading the review in more detail, it seems like a lot of their issues had to do with maybe preconceived notions about issues with pasireotide and not really understanding that this is kind of a different drug and maybe with a different side effect profile. I will say that I was a bit, I'll say disappointed when I first saw the letter because it's 3 pages long and has 20 bullet points. I was a bit overwhelmed, but Dr. Kraus, who's in the room, has assured me, and Dr. Roca as well, that these do seem to be addressable. So I've actually listed, and you go to the next slide, there's a lot of these. I was hoping just to talk about some of the red ones because I think those are the most material, and I'd love to get your thoughts. So first, and this is something we didn't anticipate, but they did ultimately say that they want a blinded control. We ended up, as I think Dr. Lowy mentioned earlier in this meeting, we initially had wanted a matching placebo, but when we got a bid for that, it was going to be $300,000 to $400,000, and the drug company said no way. So then we said, well, if we can't get a matching placebo, let's just, because the primary endpoint is relatively objective, let's just go with nothing. The steering committee didn't like that, and they want some type of blinding, either with a non-matching placebo, so saline in a syringe that a nurse injects, or something like a Band-Aid, where at least the surgeon is blinded. And so I guess my first question for the group is, from a feasibility standpoint, does anyone see an issue with having a non-matching site manufactured placebo administered by a nurse? So 2 cc's in a syringe, injected sub-Q. We're leaning towards this, but some of the study team members, including Catherine, are really nervous about how this is going to impact its feasibility and implementation.
What do people think? Dr. Lowy's getting up. He looks frustrated.
No, I love the one about clinically relevant, clinically relevant. That's legendary. I guess I don't understand what exactly Catherine's concern is. I mean, I think the biggest barrier will just be operationalizing it at each site, because this is going to be a pharmacy driven, issue with preparation, and obviously, but other than that, I mean, to me, it's not going to impact our ability to accrue. That's not going to have any effect on it. So
I think if that's what they want, it'll take a little bit of, hurdles at each institution to probably get their pharmacy committee, et cetera, to get the standard operating procedures set, but I wouldn't let that stop anything. I think it's.
I think her concern is that, the surgeon walks in the room while, maybe sees the box of lanreotide versus sees like a.
No. So I think the way to
Like
do
that's-
this is, it gets done in the pre-op area, before the surgeon sees the patient, and that's easy to operationalize, I think. Let's see that.
So I agree when they, you read enough of these things, when they ask for something, you give it.
Yeah.
And they'll fund you. And you do the study. It's still double blind. It's double blind to the patient, it's double blind to the surgeon. And what a syringe looks like, the patient doesn't know or care. And so in hindsight, it was a reason not to do it, but there's a lot of reason to do it.
Yeah.
And so.
Yeah, I agree. Yeah, when you'll see, Jonathan, as you get these feedback, when you get feedback, sometimes, things you think are just silly. Sometimes you have to compromise just to get the study done, just to get the study open. And this is a good example of something you think is silly, but if that's what they want, that's what they want. Yeah.
Okay, if the group,
Elevate impact, the ability to get into it.
sorry, I'm having trouble hearing.
Oh, yeah, so if you could speak in the mic, Dr. Lowy basically said that it will actually increase the impact of the study. And so that when it's time to publish, it's going to look, sexier, so to speak.
Yeah, Lee Ellis said the exact same thing at the early stage investigator course. He was worried that it would really impact its ability to get accepted if we didn't have a placebo. So as long as people don't think it's a huge logistical hurdle, we'll add it and.
Yeah.
And
I want to go back to the first point and to ask people's input in terms of distals versus distal plus Whipples. What's our input on this here?
So this is a much cleaner study. It's a smaller study. It's easier to do so if you're just going to do distals. One of the things on the review is they were wondering, and Jonathan can add, is basically how is it going to impact? Because one of the things they asked is, what's the next study? How is it going to impact if you do a Whipple study? It will impact that, right? If it affects it, people are going to start using it, and that's just the way it's going to be. But certainly it's not a.
So yeah, I can comment on that. So this was done for two reasons mainly. Number one, feasibility. The effect size in the distal group in the phase 2 study was much larger than the Whipple group. So it's like 3 versus 20%, 25%, or 13 versus 18%. So the sample size needed for a Whipple study was going to be like almost 700 or 800 patients. So that was one. The second was, we think that by reducing the technical variability in the surgery, we can more accurately evaluate the physiologic impact of the drug. So again, you're not having all sorts of different types of PJs and things. Most people just staple. And so that's, again, as Robert said, a little bit cleaner, but that's why we chose that. But at the end of the day.
But then you're going to have to control for how people, perform their distals.
Well, the data would show that hand sewn, stapled, seam guard, no seam guard, all are the same. And so that's why we don't think we need to control for that.
And I think their concern is, how is this going to impact future studies for Whipple, and that will people start using lanreotide all the time? And I mean, we know from our experience that lanreotide has worked in our hands, and we still don't use it because it's extremely expensive. And without an anchoring study to make it something that people want to, that insurance companies are going to say, okay, we'll pay for it.
That's a good point.
Right. That's going to be the issue as far as the future is going to be, what does insurance, dictate? Because I think if we all believe it, we all might use it, but if it's not reimbursed, it won't be able to be used. I think all your points, Jonathan, are very well taken. And I think there's no concern over technical issues with respect, especially with respect to distals, because there's 100 studies showing it doesn't matter how you close the remnant, the leak rate's not different. So I think your rationale for doing distals only is very strong and very reasonable. And so I think you can the best way to justify is to say the size of the study, number one, it's much cleaner to do it this way. And number two, the size of the study will, double or triple, which makes feasibility an issue if you include pancreatic duodenectomy. I think that's a strong rationale as far as a response.
Thank you. Any other questions, Jonathan?
Yeah, maybe on the next slide, the only one other thing I wanted to ask, again, it was a long letter, so a lot of stuff.
By the way, Jonathan, that's not a long letter.
Okay.
You haven't seen a long letter.
Oh, fair.
That's a pretty benign letter.
What was this point about stratification and risk factors? And we've talked about this at previous meetings, but I think this is a material question that I want to be really careful about answering. So, as you guys know, in Whipple's, they're very, the fistula risk score is kind of the gold standard. Duct size, pancreatic gland texture, blood loss, and pathology. In distals, it's really not. It's not as clear. There are two competing fistula risk scores for distals that were just published actually a year ago. And actually, I have them on the next slide if you mind moving over one more. It's the despair and the distal fistula risk score. And you can see, while they're kind of similar, the risk factors for leak are different in the different risk scores. And so we ended up, because it's not as clear, and this is relatively new data, we didn't end up including stratification. But in the letter, several times, they're like, how are you going to stratify? And they mentioned gland texture and things that actually don't apply to distals. But given these things have shown some signal, does anyone think we need to stratify?
So my thought is, that thickness comes across in both studies, and I think most of us who do this, that thickness is an issue, especially when you're stapling. And so I think I might include one factor, but the whole point of randomization is the fact that you're going to account for a lot of these issues in the randomization. And so I think unless something is pretty strongly validated, and again, you make the point in distals, there isn't anything that's really strongly validated. And I might throw them a carrot and say, thickness, maybe, because it's in these, or we would consider using that. But beyond that, there's nothing that's validated, and there's a randomization scheme.
So that's going to include, or I guess involve, and I presume, central review, or I guess a pre checklist where they measure the thickness on CT. It definitely complicates enrollment a little bit. And I guess I just like the group's thoughts on that.
But you can look at that retrospectively. You don't have to.
No. Yeah, I think they're asking again, and I just got the letter, but I think
I wouldn't do this in terms of stratification. I would do this retrospectively.
Well, yeah. Again, and we always were playing on that, but
also they'll change the statistics, and it might increase the N needed. I would imagine
it gets to. I mean, Andy's point's spot on. You're randomizing, so you're going to have equal number of patients in both arms. And then you can look retrospectively at your fistula risk score to see if it made a difference. But you can't, if you start stratifying based on that, it's going to become very complicated and change the sample size.
So I said this several times at the meeting about randomization, and in their response, it didn't seem like they liked that response. It seems like they were saying pre-randomization stratification.
But it's the same response you had to the Whipple question. It's going to change the sample size and make the study prohibitive. And there's nothing validated. Yeah. There's nothing validated. Yeah.
Okay. Listen, I want that to be the case. I just hope, I just don't want to, it's a give and take with this group, with the steering committee.
It's explainable. It complicates the study immensely to start to figure that out in the OR. So we'll explain it again. This is not going to be the issue. It's going to hold up.
Yeah. All right. With that, we're going to close this session. I want to thank everyone who spoke today. I think we had a lively discourse. Everyone have a safe return home, and we'll see you in Seattle. Thank you.